Let's dive right into neurorehabilitation for spinal cord injury patients. So this is an image of the spinal cord, and we can see based on this picture where different parts of the spinal cord travel. So where different sensory tracts, different motor tracts, and depending on where damage to the spinal cord has occurred, impacts which of those tracts have been affected. So complete spinal cord injuries are going to affect all of the tracts, and that's why we see sensory loss and motor loss. But we're going to discuss a couple of different types of spinal cord injuries throughout this lecture, and it's important to keep this injury or this image in mind because it will help you discern how the injury is going to affect the patient. When we talk about spinal cord injuries, we look at it based on the level of the injury, and that's how these diagnoses are named. The neurological level is defined as the most caudal segment with intact sensation and anti-gravity muscle function strength. So functional muscle strength is defined as at least a 3+ out of 5. So when we take a look at an ASIA assessment, which you'll get a handout of in class, but also we're going to try to watch a video here. If it doesn't play, you'll watch it on your own. I have the link posted right underneath the video. They're going to assess both sensation and motor function at key points. And that level that they're able to get intact sensation and anti-gravity muscle strength is where the level that the injury will be named for. So we can define spinal cord injuries based on their presentation, and tetraplegia is going to be injury to the cervical region, which results in impairments in the upper extremities, lower extremities, trunk, and pelvic organs. And comparing that to paraplegia, which is injury to the thoracic spine or lower and results in varying degrees of impairments to the lower extremities, trunk, and pelvic organs. The patient's level of function is going to depend on the level of the injury, and we're going to take a look at that a little bit more in depth here in a little bit. Cauda equina injuries are going to be injury to the spinal roots at L1 or below. So after the termination of the spinal cord, where we just have the nerve roots that are descending, that's where we would consider it a cauda equina injuries. Spinal shock is going to be the initial response to a spinal cord injury, and that is where we see a different response initially than what a spinal cord injury typically presents as. And so that patient presentation is going to include flaccidity, areflexia, loss of bowel and bladder function. So we see a lower motor neuron presentation in spinal cord injuries in the initial spinal shock phase, despite the upper motor neuron progression as they move forward. So this is the video we will try to play. And just like the others, it doesn't seem to want to, so I have the link right underneath of there if you want to just type it in instead of having to open up the PowerPoint, but it also should be embedded in the PowerPoint for you. When we look at ASIA assessments, there are key points that are assessed for sensory that correlate with the dermatomes, and then there are key muscles that are assessed for motor innervation, and these don't exactly run directly parallel with the dermatomes that you learned earlier in the year, and so it's important that you pay attention to the differences in presentation here with which muscles are being assessed for an ASIA assessment versus just a myotome screening. And you want to be able to determine a patient's ASIA score based off of a patient description in preparation for your exam. So if we're qualifying a patient at C5, then we expect them to have intact elbow flexors. C6, intact wrist extensors. C7 has intact elbow extensors. Patients with a C8 injury have intact finger flexors. T1, intact finger abductors. L2, intact hip flexors. L3, intact knee extensors. L4, intact ankle dorsiflexors. L5, great toe extensors. S1, ankle plantar flexors. The mechanism of injury can often influence the type of damage that occurs to the spinal cord, and based on the type of damage that occurs, that can also affect the location of damage and how that patient then will present. So patients who experience a mechanism of injury that involves cervical flexion and rotation typically experience posterior spinal ligaments rupturing. The uppermost vertebrae is displaced over the one below it, and we see transection of the cord most commonly associated. And so we'll typically see complete spinal cord injuries when we see transection of the cord. Cervical hyperflexion injuries are going to cause wedge-type fractures of the vertebral bodies, which often leads to anterior cord damage. Cervical hyperextension injuries are the most common in the older population secondary to falls. It causes damage to the anterior longitudinal ligament with oftentimes rupturing and causes a central cord injury. And compression fractures, where bone fragments and disc fragments can be displaced in the vertebral canal, will cause varying presentations depending on where those fragments may have caused disruption to the spinal cord. The type of lesion is also going to matter. We have complete lesions, which means there's no sensory or motor function preserved below the level of injury, including the bowel and bladder region of S4 and S5. And so on ASIA assessment, these patients will not have a preserved anal wink. And then we have a variety of incomplete lesions. Brown-Séquard syndrome happens when there's injury to half of the spinal cord, and so this patient will experience loss of motor function, proprioception, and vibration on the same side of the lesion, and then loss of pain and temperature sensation on the opposite side of the lesion. Patients who experience damage to the anterior cord will be diagnosed with anterior cord syndrome, and they will experience bilateral loss of motor function, pain and temperature, and then they'll have preservation of proprioception and vibration sense bilaterally. Central cord syndrome is going to present with bilateral loss of motor function below the level of the lesion, with the upper extremities typically more involved in central cord syndrome than the lower extremities. And they will also have bilateral loss of pain, temperature, and light touch below the level of the lesion. Dorsal column syndrome, or posterior cord syndrome, will present with a loss of sensory function bilaterally, but they'll have a preservation of motor function because only those sensory tracts tend to be involved. Conus medullaris syndrome, you expect to see a spastic bladder and mild weakness, comparing that with cauda equina syndrome, where you would expect to see a flaccid bladder with incontinence and motor weakness. So we see more weakness with cauda equina than we do with conus medullaris. This image, and I believe there's one more on the slide after it, just kind of give a visual representation of those different injury types that we just discussed. The visual over on the right side kind of gives you a breakdown of the innervation based on the level of injury, so you can understand what structures would be more likely to be involved based on an injury at that level. And then there's the breakdown of tetraplegia with paraplegia, and in a complete spinal cord injury versus an incomplete spinal cord injury, as well as the breakdown of the different types of incomplete injuries that we just discussed. So just a visual representation to make it a little bit clearer for you guys. And then this, does not go into depth with the other ones. It just elaborates on conus medullaris and cauda equina, which weren't shown on that last slide. Clinical manifestations of spinal cord injury, so basically how we expect the patient to present. We can expect to see motor paralysis, sensory loss, cardiopulmonary dysfunction, impaired temperature control, spasticity, which is often treated with medication, and in patients with spinal cord injury, baclofen pumps are very commonly used to be implanted in the patient's abdomen to disperse at the spinal cord and decrease levels of spasticity. Patients will also experience bowel and bladder dysfunction and sexual dysfunction. Because of those clinical manifestations, we can have different complications following spinal cord injury. And I want you to pay special attention to these complications here because I'm going to give you instructions to prepare for class on the next slide. But starting off at the top, we have pressure ulcers. We want to make sure that we are instructing these patients to perform pressure relief for 1 minute every 15 to 30 minutes in the seated position and reposition every 2 hours in bed. Because of the decreased sensation, patients following spinal cord injury are at an extreme risk of developing pressure ulcers, and so we need to educate them on skin checks and pressure relief techniques and all of those things. Another complication that is common with spinal cord injury is called autonomic dysreflexia. This happens to patients who have injuries above level T6. Clinically, and in some of your textbooks, we'll reference level T10. For the boards, I want you guys to know T6, but for clinical presentations and just something to be aware of for your patients, I want you to think about autonomic dysreflexia with patients with an injury from T10 or above. And basically what happens with autonomic dysreflexia is the body's autonomic nervous system goes out of control and it's responding to something that it doesn't really know what it's responding to. And this is typically a noxious stimuli. And remember, noxious means painful, but something that the patient is hurting the patient, but the patient can't necessarily perceive as pain. And so the autonomic nervous system goes out of control. We see the patient have an elevated blood pressure. We see them become diaphoretic. They may have changes in breathing, changes in color. They can turn red, and this is a medical emergency. This is something that we need to pay attention for, and we need to basically remove whatever is causing it. So we want to get rid of the source of the noxious stimuli. So we'll sit the patient up and we're going to look for the noxious stimuli and remove it. The most common sources are going to be something like a kinked catheter or a roll in compression garments or a fold in clothes, something pinching their skin in their lower extremities that they don't have the sensory ability to perceive what's happening, and so their body's response is dysregulated. We also can look at complications such as postural hypotension because of the decreased muscle tone. There isn't the ability to maintain the blood pressure when moving into upright positions, even if it's just an upright seated position. And so these patients will typically need some training for tolerance to upright. We'll also have pain, which can be inconsistent with what the patient is actually able to perceive because the nerves themselves have been damaged. And so there can be neural pain as well as pain to the actual body, especially if the spinal cord injury has been caused by a trauma that has resulted in multi-body region injuries. Patients following spinal cord injury are at significant risk for contracture, especially because they can't move on their own, and so range of motion and stretching are going to be common interventions that we're going to implement quickly and often. Heterotopic ossification, also known as myositis ossificans. This is something that is most common in the spinal cord injury population. They don't really know the cause of it, but it's basically when there is bone formation within the soft tissue, typically the muscle belly, but it can form within the tendons or ligaments as well. And it's calcium deposits or bone formation that happens where it's not supposed to. And patients with heterotopic ossification will present with decreased range of motion, swelling, and warmth in the area that they're having the abnormal calcium deposits. And it's often associated with infections elsewhere in the body with spinal cord injury patients. Further complications to be on alert for are going to include deep vein thrombosis. Patients following spinal cord injury are at an increased risk of DVT, so we need to monitor for signs and symptoms of that. They're also at increased risk of developing osteoporosis, primarily because they end up having decreased weight-bearing abilities, losing the ability to stand and have the functional weight bearing to promote that bone density development, results in an increased risk of osteoporosis. Patients are also at risk for respiratory compromise, often because their respiratory muscles are involved, whether that's their direct respiratory muscles or their accessory breathing muscles. There's still decreased muscle activity to move the rib cage and help change the pressure to draw air into the lungs. And so there is respiratory compromise that's experienced. Pneumonia and septicemia are the number one causes of death following a spinal cord injury. Because of the inactivity, these infections can become deadly. Septicemia may or may not arise from respiratory compromise. It can come from infection otherwhere in the body, but it can also be associated with respiratory compromise. And so that's one of the reasons to note it under this. And then bladder and bowel dysfunction and sexual dysfunction can be considered clinical manifestations and complications. And so we need to know that they're things that can present that the patient is aware of and has gotten used to, and they can also become complications throughout the course of treatment that we need to educate the patient on as we go. So I want you to take a look at the complications from this slide and the last one and ask yourself what kind of clinical presentation you would expect to be indicated that the patient is demonstrating a risk of each one of these complications and how you would respond or prevent the complication in the first place. And have those written down on a piece of paper and be prepared to discuss them in class after your quiz. The functional potential of a patient following a spinal cord injury is going to depend on the level that the injury occurred. And so there's some basics that we can expect out of functional levels based on that level of injury that we're going to discuss here a little bit, so that way you can plan your treatment sessions accordingly, and you can also provide education on appropriate patient expectations. We're not going to talk about setting ambulation goals with somebody with a C7 spinal cord injury because they don't have innervation to most of their trunk and neither of their legs. And so that's not a realistic goal, and we need to be able to shape that for patients as well. So patients with a spinal cord injury from C1 to C3 are definitely going to be on mechanical ventilation. Remember that C3, C4, C5 to stay alive. Those are the levels that go to the phrenic nerve to innervate the diaphragm. And so when we have injury to C1 through C3, these patients typically don't survive, but if they do, they will require mechanical ventilation and a sip and puff wheelchair for mobility. C4, they typically can have full innervation of the diaphragm through neuroplasticity of maintaining whatever levels at C4 and C5 to get to the diaphragm, and so ventilatory compromise becomes less of an issue at C4, but it does not mean that they will have full respiratory capacity, nor does it mean that they won't require mechanical ventilation at the acute phase of their treatment. They have full-time activity of daily living care, so these patients will require full-time care to complete ADLs. Injuries at C5 will have limited to no innervation of deltoids, biceps, and rhomboids. So we've got limited shoulder motion, but very little, and no elbow motion really. There's limited functional ability at C5, and this is the highest level that can contribute to rolling. So patients with an injury from C1 to C4 are going to be dependent with rolling. They will not be able to contribute any to the physical task. Patients with injury at C6 are going to be independent or can achieve independence with rolling, feeding, and dressing. Again, this is going to require intervention, but this is their functional ability. And they also have the ability to propel a manual wheelchair, typically with some modification, but C6 is going to be the first level where we're going to start thinking about, okay, we can look at manual wheelchairs instead of power mobility for these patients. At C7, we expect them to be able to achieve independence and self-care with the performance of ADLs. It can be possible that they can drive with adapted hand controls. And this is the highest level that can do independent pressure relief because C7 is correlated with elbow extensors, and so the ability to extend the elbows and elevate the pelvis from the sitting surface is what is necessary for that independent pressure relief. So C7 is going to be the highest level that can do that. At C8, we expect these patients to be able to live independently with appropriate physical therapy care. And they should be able to perform wheelies in a wheelchair that can help them with obstacle negotiation out in the community. At T1 to T9, we should see improved trunk control because we at least have some levels of the trunk being innervated. And they should be able to produce a productive cough because they have enough innervation of those respiratory muscles to get secretions out. From T10 to L3, these are going to be our therapeutic ambulators. So they will walk in therapy, but they're primarily going to use a wheelchair for household and community ambulation. Our goal of therapeutic ambulation is going to be promoting the weight bearing, getting some of the functional stretching to muscle groups that we need, but it's not serving a purpose for actual gait training for transferring over into functional mobility. It's for the more physiologic purposes. From L3 to L5, we should see quadriceps function, and these patients should be able to ambulate with an orthosis. So this chart breaks down different levels of injury with what types of functional activity we should be able to expect them to be able to perform. This chart does the same thing. It's just really which you prefer to understand the information by. And I actually believe there's a chart in your textbook as well. So however you would like to understand this information, but it is important to know the expected functional outcomes for a patient based on their level of injury. So that way you can tailor your treatment plan and you can provide appropriate patient education. Because respiratory compromise is such a common complication of spinal cord injury, some of our initial interventions are going to focus on breathing. And so we're going to look at breathing exercises such as glossopharyngeal breathing, and you can take a look at this video on your own time on what GPP breathing is and how to teach it to patients. We're also going to look at lateral expansion of the rib cage. Is the patient able to get enough expansion? Do we need to do mobility exercises to improve that expansion? Is there strengthening that can be done to improve it? We can use things such as incentive spirometry and flutter devices to help improve respiratory strength or respiratory muscle strength, and do exercises such as chest wall stretching and pec stretching to encourage full rib cage expansion. We'll also need to utilize things like postural drainage and teaching patients how to cough, especially if they have impaired diaphragm function. Beyond breathing interventions early on, we're going to focus on things like range of motion, strengthening, and acclimation to upright. So our range of motion, we want to make sure that we're able to maintain a tenodesis grip for our patients. And so patients following spinal cord injury, if they have activation of their wrist extensors, remember, due to passive insufficiency, this will cause their fingers to curl when they pull into wrist extension. And so patients following a spinal cord injury will maintain a functional grip with what we call a tenodesis grip. And so they will use that wrist extension to grasp objects and get the finger flexion needed for that grasp. Because of this, stretching of the finger flexors should be avoided. We need that tension in those finger flexors for that passive insufficiency to maintain a sufficient grip with wrist extension. They also must have active wrist extension for functional tenodesis grips to work. Passive range of motion is necessary throughout the body, especially because of the risk of contractures due to abnormal tone and positioning following spinal cord injury. There is a table on page 474 that reviews range of motion requirements for function. And so these are going to be our passive range of motion requirements in order to complete functional activities such as wheelchair mobility, transfers, dressing activities. So you need 60 degrees of shoulder extension, you need 100 degrees of hip flexion, and 45 degrees of external rotation. And those things are all going to contribute to a patient's ability to perform ADLs. And if they do not have the sufficient range needed, then they're not going to be able to complete those ADLs. Strengthening exercises, we're going to have different emphasis depending on where the level of injury and how many muscle groups are affected. Key muscles to strengthen for patients with tetraplegia are going to be the anterior delts, the biceps, and the shoulder extensors. Key muscles to strengthen for paraplegia is going to be the shoulder depressors, the triceps, and the lats. And those are going to contribute more to our ability to transfer and functional mobility. And then acclimation to upright. Oftentimes patients following spinal cord injury will have issues with postural hypotension because of decreased tone in the extremities and the vessels to help promote blood flow back to the heart. And so we will have to utilize the tilt table to get them acclimated to upright. And we can also use things like tilt and space wheelchairs to achieve this. After their stay in acute care, most patients following a spinal cord injury are going to transition to inpatient rehab because they're going to require an extended length of stay with extensive therapy interventions in order to maximize their functional independence for a safe discharge home. During an inpatient rehab stay, the goals of physical therapy are going to be to strengthen key muscle groups, promote independence in skin inspection and pressure relief, increase passive range of motion of the hamstrings and shoulder extensors, increase vital capacity, increase tolerance to upright positioning, increase independence in transfers and directing a caregiver depending on the patient's level of injury, promoting independence in wheelchair propulsion on level surfaces, promoting independence in operating a motor vehicle as appropriate, returning to home and school or work, promoting independence in a home exercise program, and patient family education and instruction. So whatever interventions we are giving a patient following a spinal cord injury in the inpatient rehab setting, they need to be geared towards one of these goals. The intervention should help in achieving one of these goals. When looking at our earliest interventions, we're typically going to take it back to the developmental sequence, and we're going to start with proper positioning and promoting greater positions that require an increased challenge to the trunk and overall body stability. And so we'll start with mat activities, again going through that developmental sequence of prone to prone on elbows, rolling from prone to supine, practicing moving from supine to supine on elbows, which can then transition into long sitting. And so there are pictures of those progressions in your book, and we're going to work through those in your lab activity. But working on all of these functional positions that correlate with the developmental sequence are important following spinal cord injury because it helps to build the patient's balance and stability from the trunk out. Rolling activities should also be performed because remember, pressure relief is going to be a huge part of this, and so the greater independence we can promote with rolling, the better off the patient's going to be at avoiding skin breakdown. Rolling activities in supine should always be initiated with cervical flexion and rotation towards the direction of the roll to assist the patient in performance. And then rolling activities in prone should always be initiated with cervical extension and rotation away from the direction of the roll to assist in the patient performance. There are various transfer types that we're going to utilize with patients following a spinal cord injury, and the transfer type that you're going to train the patient how to perform is going to depend on their level of function and any complications associated with their injury. And so we're going to review all of these and practice them in lab. You should also have refreshed yourself on them in order to train your rad tech peers. But you want to make sure in your preparation phase you are providing sufficient education. Your patient needs to know what to expect during the transfer, and you also need to make sure that your equipment is set up in a way that everybody is going to complete things safely, considering not only the patient's body mechanics and their safety, but also your body mechanics and your safety. You can utilize a 2-person lift, a sit pivot transfer, a modified stand pivot transfer, an airlift, which can be preferred for patients with strong extensor tone. Airlift can also be qualified as a Hoyer lift. Sliding board transfers, prone on elbows transfer, rolling out of the wheelchair, and lateral push-up transfers. And lateral push-up transfers must be a C7 or better for tricep strength in order to elevate and get that elbow extension. So our initial treatment is going to involve getting the patient into those various positions that we discussed. And then we want to progress to transitioning them between those positions and then keeping them holding those positions independently while we superimpose some other kind of movement, whether that's upper extremity motion or for reaching, or we're incorporating weight shifts so that we're getting trunk movement. But it's a progression of motion within each of those positions that we discussed on the last slide. So we'll continue to promote functional independence in prone progression positions and functional training within those positions. And we want to promote independent self-range of motion. A patient in the intermediate phase of therapy in inpatient rehab should be able to perform self-stretching of all of the at-risk muscle groups. And again, this is going to vary depending on where the patient's level of injury is, but we're going to go through the most important stretches to teach your patient during your lab activity. Advanced treatment interventions are going to include our advanced mat activities, and these are primarily aimed at increasing the patient's functional independence and promoting their carryover to their functional needs. So you can look at these on the pages listed here. We've got the sitting swing through on page 492, your hip sway, the trunk twisting and raising, the prone push-ups, forward reaching, creeping, and tall kneeling as intervention ideas. I want you to review these advanced activities in your textbook and then be prepared to demonstrate them for your classmates by random selection. So you should be familiar with all of them so that you can demonstrate any of them. As the patient progresses and is able to perform basic transfers like chair to mat, we need to prepare them for higher functional demands and things that can happen throughout the course of life. And so we will progress to advanced transfers such as wheelchair to floor transfers, which you can find on page 496 and 497, and also righting the wheelchair in case the patient tips the wheelchair, and that's on page 498. Advanced wheelchair skills are also going to factor into our patient progression because wheelchair mobility is the primary means of locomotion for patients following a spinal cord injury, and so we need to focus on their safety and ability to navigate different obstacles. So we will practice performing wheelies. We want patients to be able to find that balance point and working over a mat, so that way if they do tip backwards, they are safe. We're not going to have any head injuries, and then if they do tip backwards, can we work on righting the wheelchair from that position? Wheelies are important for being able to navigate obstacles in the community, especially if we talk about ascending curbs and ramps. And so practicing wheelies can be important before implementing those obstacles. When we teach patients how to ascend and descend ramps, the safest method to descend is backwards with the patient leaned forward, but this can be difficult for the patient due to their inability to see where they're going. And so a controlled wheelie is also a way to, that's for a curb. So, we can teach a patient to descend a ramp in a forward direction, but we need to make sure that we're careful of not only their hand control to be able to keep the wheels from sending them down the ramp too quickly, but also where their body is shifted. When we have them descend going backwards, gravity is pushing them further back into the chair, and so they're in a safer position versus descending a ramp in a forward direction. Gravity is going to have them sliding forward out of that chair, and that can be a safety concern. When descending, encourage the patient to approach with the wheelchair facing forward and the patient leaned back in the chair. And when ascending, the patient should be leaned forward in the wheelchair. If they're going up a long ramp, we want to teach them to use long pushes. But if they're going up a short ramp, that typically means that it is steeper, and so we want to use short pushes so that they don't roll backwards in the process. When going up and down curbs, we want to ascend in the forward direction and descend backwards or in a controlled wheelie. We have to practice powered mobility because there is a substantial difference in safety with powered mobility compared to manual mobility with the wheelchair. And so if a patient does require powered mobility, that needs to be included in your wheelchair mobility training, and what differences you encounter in the ability to manage a powered chair over obstacles such as curbs and ramps compared to a manual chair. Ramps tend to be easier than curbs with a power chair than a manual chair, but there are a lot of really fancy power chairs out there now that curb negotiation may actually be easier in some of those power chairs. And so knowing what your patient's going home with is also an important component to that. And on the topic of wheelchairs, if your patient is using a wheelchair as their primary means of locomotion, which means that they are not a community ambulator, which is really going to be our L2s and below, so anybody with a spinal cord injury above L2 is probably going to be using a wheelchair for at least a large portion of their locomotion. We need to make sure that they have a good pressure relieving cushion. Roho cushions are probably going to be our best recommendation for this patient population. And there's a picture of one here on the slide where you can see there's different air cells to help distribute the weight and decrease the risk of pressure ulcers while seated in a wheelchair. Remember, these patients have sensory deficits, they're not able to perceive, and we can do as much education as we want on pressure relief, but we also want to provide them with the best resources to not have high risk of skin breakdown. During the advanced treatment intervention stage, we're going to have achieved functional independence for most activities, and the goal at this point is to improve functional capacity, so how much the patient is able to do at one time on their own. So we're going to need to utilize cardiopulmonary training for this. Patients with injuries above T4 generally exhibit a heart rate max of 130 beats per minute. And so we need to keep that in mind when we're looking at how their heart rate responds to exercise and how closely we're working them to that heart rate max. But because they have a heart rate max that isn't dependent on their age and it's much lower than the age-dependent heart rate max, we typically want to use the RPE scale with this patient population to promote increased cardiopulmonary activity. Our target range for this population is going to be between a 12 and a 15 on that 20-point RPE scale. Circuit training has also been shown to have substantial improvements in patients with spinal cord injury, with the ideal dosing being found at 8 to 10 reps per crest to 3 sets of general whole body muscle strengthening exercises for 2 or more days per week. And we also want to utilize aquatic therapy as appropriate with this patient population because it serves to decrease abnormal muscle tone, increase muscle strength, improves pulmonary and cardiovascular function, and provides opportunities for standing and weight bearing that may otherwise be unavailable to a patient with a spinal cord injury. We just need to remember our contraindications to aquatic therapy. So our contraindications are going to include a patient with a fever, infectious disease, tracheostomy, uncontrolled blood pressure, vital capacities less than 1 liter, urinary or bowel incontinence, and open wounds or sores that can't be covered with an occlusive dressing. And these contraindications can apply to a lot of patients in the spinal cord injury population. And so while aquatic therapy does have substantial benefits for these patients, we have to consider the possible contraindications and how it applies to our specific patient before implementing aquatic therapy. Ambulation training will be appropriate in some patients following spinal cord injury, and we want to remember to be realistic with our goals and what is functionally possible for this patient and this patient population. So in general, the patient should be independent with mat mobility, transfers, and wheelchair mobility on level surfaces before trying to initiate gait training. And the populations that we can initiate gait training with are going to be our therapeutic ambulation, our household ambulators, and our community ambulators. So T2 to T11 is going to be our injury range where therapeutic ambulation and standing may be possible. T12 to L2 have the potential to be household ambulators, and L3 and below can achieve community ambulation with the appropriate support. Oftentimes, assistive devices and orthoses are going to be that appropriate support. So orthoses can be required for greater stability, but they can also restrict normal performance of functional tasks such as a sit to stand. If you look at intervention 13.28 on page 511, you can see how a normal sit to stand is modified through the use of KAFOs with the knees locked in extension. And we can practice those in lab as well. When we are initiating gait training, standing in the parallel bars should be the very first step. We need to get the patient to be able to find their balance point and stabilize themselves in the parallel bars, and then work on weight shifting and the ability to respond to displacements to their center of gravity. The gait progression should be initiated with jackknife training in the parallel bars before the progression to taking steps. So jackknifing is where the patient would elevate on their arms and pulling their head forward and their hips backwards so that their body kind of folds like a jackknife. And we practice this in order to prepare them to swing their legs forward together for the gait sequence. We would start with a swing to gait pattern before working to a swing through gait pattern, and there are pictures of this in your textbook, but we can also practice it in lab. And sitting activities, remember we talked about how orthoses can limit the ability to perform normal functional tasks, and so if a patient is ambulating with orthoses, sitting can be a huge component of gait training because the ability to return to their original position safely needs to happen in order for gait training to be safe overall. And so we need to remember when utilizing a locked orthoses, the chair must be at least 12 inches behind the patient for safe seating. And we normally want to practice this with the chair pushed up against the wall so that it can't move away from the patient. If a patient is capable of hip flexion, then we typically want to try to promote something that's less of the jackknife with swing through pattern and more of a normalized gait pattern, whether that's a 2-point or a 4-point as appropriate. And so we want to maximize the patient's functional potential with the most appropriate gait pattern based off of what innervation they have and what muscle activation they can achieve. We need to make sure that we practice backing up because that is another integral part of gait training. And gait training with crutches, if we are teaching somebody how to walk, we also need to teach them how to fall, because falling is an inevitability, but especially when we're walking with an assistive device, we have extra safety risks of things we can fall on. And so training our patients, if you're going down, get rid of the crutches, get them out of the way, and fall safely, and how to fall without bracing themselves on an arm and trying to remain as limber as possible for their land. We also need to train them from getting up from the floor, because if they fall, we have to be able to get up. And I want you guys to review intervention 13.30 on page 513. We will practice that in lab. That's another one that I would be prepared to randomly demonstrate for your classmates. And negotiating environmental barriers. If we are ambulating, we are likely going to encounter environmental barriers the same way we would if we were practicing wheelchair mobility. And so ramps, we're going to swing to ascend and swing through to descend. With curbs, we're going to ascend with the crutches first and descend with the crutches first. And for stairs, we can ascend going forwards or backwards. And again, it's going to depend on what the patient's functional ability is. Another advanced intervention for patients following spinal cord injury can be body weight support treadmill training to help improve muscle firing, improve gait mechanics, and decrease strain on the body with needed strength to overcome gravity for those proper gait mechanics. The other thing that body weight support treadmill training can be good for is just promoting the weight bearing through the bones for increased bone mineral density and decreased risk of osteoporosis. So this might be a situation where therapeutic ambulation is really more appropriate. We're not using body weight support training to get the patient to a more functional ambulation, but we are using therapeutic ambulation to get the range of motion, the weight bearing stretching, the weight bearing bone mineral density contributions, and all of those things. Discharge planning. Discharge planning conference should have the whole team, including PT, OT, speech if appropriate, nursing, doctors, everybody discussing the patient's overall functional status and their ability to return to a normal version of their life. Because somebody returning from a spinal cord injury obviously is going to have a lot of modifications to what they can and can't do, but the goal of the whole team is to get them to the most normal version of their life that they can, and whatever adaptations are required for that need to be discussed with discharge planning conferences and determining the patient's discharge disposition, where they're supposed to go, what barriers might exist to that, what equipment they need to be able to overcome those barriers or to achieve the adaptations that they need. And so procurement of equipment becomes a huge component of that. Educating the patient on the home exercise program, not only for strengthening and continued functional independence, but remembering range of motion is such a huge need for this patient population, and the risk of contractures due to abnormal muscle tone. We need to make sure that they are completely self-sufficient in self-stretching activities. Family teaching is important, especially if the family needs to contribute to things such as transfers or any other mobility, dressing tasks, eating, bathing, any of those things. We need to make sure that the family is interactive in our treatment sessions and that they're not learning about it passively, but they are actually getting the opportunity to practice whatever skills they are going to need to perform for their loved one at home. And we need to work on community reentry, so any tasks that the patient needs to be able to complete to, again, return to that most normalized or best version of their normal life. Emphasizing quality of life and long-term healthcare needs. Education becomes a huge component in long-term healthcare needs, and establishing the rapport with the patient early on can keep them coming back for therapy as needed and maintaining those long-term healthcare needs better. I would make sure that you review the activities that have been identified with a specific page number throughout this entire PowerPoint, so you can be prepared to demonstrate those activities to your classmates. Do not find yourself put on the spot without the ability to demonstrate it, because you have been given plenty of fair warning. Moving forward from here, I've got a handful of questions that I'm going to let you guys read through on your own and quiz yourselves. And just kind of review from this lecture. I'm not going to read the questions to you. I'm just going to let this continue to record so that you can read them. If you need to pause it, you can pause.